This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, he is a 70-year-old gentleman and he has this long-standing hypermature cataract. Pupil is not very well dilating. This is the maximum pupillary dilatation which we can get. The challenge in this is the capsule will be very fragile and really I can't see whether there is a fibrotic element in the capsule or is it a calcified subcapsular area which is being seen as a fibrotic capsule, and the capsule itself is going to be very thin, flimsy. The challenges in these cases is going to be dealing with the fragile anterior capsule and the posterior capsule, apart from the zonular weakness which we can expect in these long-standing cataract, and apart from that he also has pseudoexfoliation. So these are the complexities which we are going to expect in these sort of eyes. He is a long-standing diabetic and his general health is not so great, and that's the reason why the surgery has been delayed. Now, as the initial steps are being performed, you can see that the side port is done, the air bubble is put, preservative-free lignocaine is being put inside the eye, and the anticapsule is stained. The plan is to first expand the pupil by mechanically stretching it. I'm using Y-hooks to perform the stretching under OVD. It looks like it's really helping me out. The pupillary size is increased. Now this is a complex case and the health of the zonules is going to be clear only when I touch the capsule for Rhexis. So in the event of any complexities, I would want to convert from phacoemulsification to a manual small incision cataract surgery, and that's the reason why I'm performing a sclerocorneal tunnel incision so that I can use the scleral tunnel to help me out in the event of any complication intraoperatively. The anticapsule is incised with a 26 number bent needle, and then the flap is grabbed with the forceps and I begin performing the Rhexis. As I'm tearing the anticapsule, I'm relieved that the tearing is going on very easily, suggesting that the zonular health looks to be alright. I'm using the Sinski hook as the second instrument to stabilize the globe as the Rhexis is being performed. The Rhexis is complete, but I feel it is slightly smaller than what I would have liked, especially because the underlying nucleus looks to be slightly bulky and hard. So it's always better to have a bigger Rhexis. That's the reason I'm going in again with my micro scissors to give a tangential cut, and then the Rhexis is being enlarged to an appropriate size. And this is going to be helpful in managing the nucleus, providing lesser stress on the Rhexis margin as well as the capsular bag and the zonules. Although I usually avoid hydrodissection in mature cataracts, this is a cataract wherein the nucleus is looking like it is sticking onto the capsular bag. So I'm just using a little bit of fluid to ensure that the nucleus is free from the attachments of the capsular bag. And of course, this needs to be done very carefully by pressing the posterior lip of the incision so that we don't have a buildup of the pressure, and very little fluid is used, and then it's confirmed that the nucleus is free from its attachments to the capsular bag. Time to emulsify the nucleus. So my style in such hard cataracts is to usually create a central groove. I'm creating a small trench by sculpting the central portion of the nucleus. I'm using continuous torsional energy, 5 levels, so that I can create a central crater without much of a stress to the zonules. The central trench helps me to get a good purchase on the central core of the nucleus, which would help me to get good cracking when I perform my vertical chopping. Once I reach about 50 to 60% depth, now I'm going to change my settings to chop mode, where I'm going to use only longitudinal energy. The tip is buried into the substance of the nucleus until the sleeve is reached, so that sufficient amount of tip has been buried into the nucleus. The sharp vertical chopper goes down in, and then the lateral separation maneuvers are being performed. So the distal half of the nucleus is split, but the proximal half and the central plate is still holding on, no problem. The nucleus is rotated, again the tip is buried, the vertical chopping maneuver is continued. The posterior plate is relatively tough to separate. Chopping is continuing into the second heminucleus. Now I have a free fragment which is pulled out of the bag and emulsified in the antechamber. Chopping is continued, and the central plate is the one which is holding on. This is the endonucleus which is still not giving away. So once I have around 6 fragments, the central endonuclear plate is flipped anteriorly and that portion is emulsified, which frees up the remaining fragments. Once the central endonucleus and the plate was taken care of, I thought it's not going to be difficult for the remaining fragments. But the other heminucleus, these 3 fragments are also having posterior attachments still sticking on to each other, and emulsifying them again was a challenge. And this is a common feature which we see in these rock-hard cataracts. The message here is, you need to be very slow, and as most of these cataracts also have a weak capsular support system, so your maneuvers have to be very controlled. It's just a matter of time wherein we can have access to this posterior plate, and once we emulsify them, all these fragments are going to be released. All the fragments are emulsified, and time to remove the cortex. Time to implant the lens. At this moment, I'd just like to pause here and show there are multiple tiny dots which are posterior to the posterior capsule, and they're probably in front of the anterior hyaloid space. These small particles, these indicate the zonular weakness and probably an anterior zonular detachment. And this gives access for the fluid to permeate across the zonules and get accumulated behind the posterior capsule. And this is one of the common reasons why we can have fluid misdirection, and the posterior capsule will be pushed anteriorly and can be an important cause for posterior capsule rupture. So in such eyes with long-standing cataract, elderly patients with exfoliation, we need to expect compromised zonular apparatus, and the fluid passage across the zonules into the chamber behind the posterior capsule is a fact, and that can cause some issues in the later part of the surgery. The chamber is deepened by using viscoelastic, and then a multi-piece lens which was originally planned for this patient is then manipulated into the bag. And the OVD both in front and behind the lens are aspirated out. So that was it, the case is done, and this is the first day post-op picture of the patient. You can see these minor sphincterotomy tears, but the pupil is still small enough and is functioning well. The patient is happy with the visual outcome. To summarize, in such cases, we need to anticipate certain challenges, like we expect a difficult rhexis because the anticapsule is going to be very friable, the capsule, bag and the zonules are going to be compromised, and of course, dealing with the pupil is going to be important. Always keep in mind that such eyes have a higher chance of developing fluid misdirection in the later part of the surgery, and it itself can be a cause for some complications. Being well prepared does help. That was it. Thank you for watching and hope you found this helpful.